Good morning. Welcome, everyone. My name is Amy. I'm one of the occupational therapists here. We are so glad you've joined us in our class. We are very proud of the care we provide here, and we're looking forward to working with you in the near future when you're here for your surgery. As you saw in the video, you have many members of your interdisciplinary team while you're here. We're all here to take care of you. And today in the class, you're going to be hearing from a number of us. You're going to be hearing from nursing, from pharmacy, physical and occupational therapy, as well as case management. We will have a demonstration, rehab demonstration afterwards, and time for questions and answers. This class is being recorded, just so that you know, for patients who may not be able to attend the class and may have to watch the class on a video from home. So we wanted to let you know, none of you will be in the video. It's just videoing the screen and us up here on stage. But it would be helpful if we could hold questions till the end so that we can, not have the questions they won't be able to hear, and then, So anyway, we'll have all that afterwards. And then at the end, we'll have a tour of the orthopedic unit upstairs on 3 North Wing. So our nurse will take you around and show you one of the rooms and all of the equipment there and things, so that you'll know what to expect, and you can ask whatever questions you have up there as well. We hope that at the end of this class, you'll feel you're prepared, that you have the tools you need to ease the process to transition home. And I think that you will find that is true. Take a moment, please, to look in your folders. I'd like to just let you know these are the items that you'll see there. I want to be sure you know that the PowerPoint presentation is in the folder on the right side, so that you'll have all of the slides that we're going to go over here. If you want to take notes, that's great, but just know that all of the information will be in there. We have a course evaluation that we would love to have you fill out and return back to us at the end of the class. So we'll give you a few moments to do that toward the end of the class. And then just take a moment to look through. You have your local equipment stores list and pharmacy list and some other rehab-related instructional sheets. And with that, I'm going to turn it over to Ada from nursing. Can everybody hear okay? Is the sound volume okay?
Good morning, everyone. My name is Ada. I'm one of the registered nurses up on the 3rd floor of the orthopedic unit, and I'm here to talk a little bit on what to expect in terms of the nursing aspect of your care while you're here in the hospital. So mostly we have our type of surgeries that we have are hips, and knees, and spine surgeries. Is anybody having a spine surgery here? All right, a little bit on what to expect on a day of surgery. The physician will encourage you not to eat or drink anything after a specific time. Usually it could be 10 p.m. or 12 a.m. If you do take blood pressure medications, they encourage you to do take those that morning of, but do take them with small sips of water just to make sure that it does come down. Make sure that you do shower and wash your hair. You might not get an opportunity to do it for a few days after surgery, so it's best to do that. If given nasal swabs and special wipes or soaps, do utilize them. Some doctors want you to use it for 7 days. Others, they would want you to use it the day before. You should brush your teeth that morning of. Just make sure you do not swallow the water. Also, do not shave at or near the surgery site. We want to make sure you don't get an infection with nicks or cuts that you might get from it. Remove fingernail and toenail polish. We will be giving you a probe to check your oxygenation, and the the nail polish might impede with it. If you by any chance start feeling sick, do report any changes in physical condition before your surgery, such as a cold, a fever, rash, nausea, vomiting, or diarrhea. The physician might have to postpone your surgery if that's the case. In terms of what to bring the day of surgery, we are encouraging you to bring a list of medications and supplements that you take at home. So things like the dose, the frequency that you take it, and then also the last time that you took the medication is very important for us to know, so that we can continue giving you that. We need a copy of your medical and surgical history. a copy of your insurance card, and also your driver's license. The copay, check with your insurance company. Sometimes there's a specific amount that you must bring in order to get admitted. A copy of an advance directive if it's applicable for you. Eyeglasses, hearing aids, and with batteries if you utilize them. Important telephone numbers. If you have a cell phone, you're allowed to bring it, but do not forget the cell phone charger. Payment for discharge medications. At the end of, before discharge, the pharmacist will come over to your bed and will be providing you your discharge medications. And most of the time, the copays are around $25. If you use CPAPs and rescue inhalers, do bring those as well. Things that you can leave at home are credit cards, jewelry. It's okay to bring your wedding band. Leave at home checkbooks, and leave at home all medications unless it's a special type of formulary like a chemotherapy or any type of specific medication that you might feel like our pharmacy does not have here. And that's something that you can check beforehand. So on the day of surgery, you're going to be going directly to the admissions department that is in room G314. That's where they'll be asking you for your ID, a copy of your insurance, your copay, and your driver's license as well. After you're officially admitted onto the hospital, someone from our transport team will be helping you over to our surgical waiting area or our PTU department. That's where you'll have an anesthesiologist interview. You'll get to talk to your orthopedic surgeons as well. You'll get to sign some consents. You'll receive an ID band that has your medical record number, your name, your age, your birthday, and also a barcode. The nurses will be dispensing all medications by scanning that barcode to make sure it's the correct patient and the correct medication that is being given. In the surgical waiting area, you will also be given a hospital gown. They'll start an IV. The surgeons will also be marking the surgical site where they'll be performing surgery. Once the operating room is ready for your case, you'll be wheeled over to surgery. That's where they'll do a timeout procedure right before they start surgery. That's to ensure that we have the correct patient, that they'll be doing the correct surgery, and they'll be doing surgery on the correct extremity. Then surgery will occur. Once that's completed, you'll be sent over to the recovery or PACU area. And usually you're held there for about 1 to 2 hours just to make sure that your vital signs are stable. And then you'll be transported over to the 3 North Wing, which is where you'll see the nurses. So a little bit on the overview of 3 North Wing. The vast majority of our patients are knees, hips, spine, and shoulder. The average length of stay is 3 to 5 days, depending on your progress. Some people get to leave that second day after surgery, but it all depends on how well you do. Also with physical therapy and so on. We have 26 private rooms. Each room is equipped with a bathroom, a sink. There's also a flat screen TV, which is fun. And then you have your own closet as well. Each patient is assigned with a primary nursing team, which includes a registered nurse, a clinical care partner, which is a nursing assistant. There is sufficient staff from a charge nurse that oversees the whole unit. There is unit management that is available, and plenty of auxiliary staff like lift team and transport team as well. For visiting hours, your visitors will have to check in through the 16th Street security, the entrance, and they'll ask for their ID. They will be given a name label that they'll have to wear at all times while they're in the hospital. And if you do have anybody staying overnight, do let us know so we can there's always a recliner in the room, but sometimes we can also get a cot. So a little bit on the patient's daily routine. You will be assigned nursing for 24 hours. There's a day shift and a night shift. Day shift comprises of between 7 a.m. and 7 p.m. and then night shift is 7 p.m. to 7 a.m. Similar things happen between both shifts. For instance, in the beginning of the shift, the incoming and the outgoing nurse will be talking about your surgery or your case. They'll be discussing the plan of care, and that's all done at bedside so that you can be involved in the conversation. They'll be doing your vital signs to make sure you're fine. So the vital signs include like your blood pressure, your heart rate, your respiration, your temperature, just to make sure you're fine. Then you will be given breakfast. Breakfast opens at 7 a.m. and they close at 10:30 a.m. Between 11 and 7 p.m., you can order lunch and dinner. Medications are dispensed as well using that barcode scanning that we were talking about. And then you will be visited by the rehab department, which is physical and occupational therapy. At night, similar things happen, except that around 5 a.m., the phlebotomists, the people that come and draw your blood, will be coming to draw some blood, and that's just to make sure that your hemoglobin and your blood levels are okay. If you require sleeping aids like sleeping medications, earplugs, or eye masks, we also have that available. So we want to make sure we focus on controlling your pain while you're here with us, and that's just to ensure that you can get sufficient rest and heal better. When your pain is well controlled, you are able to move more, and that helps with your recovery process. We want to successfully transition you over from IV pain medications to orals. After you come out of surgery, you'll have IV medications, and as the days go by, you'll be utilizing less and less on that, and you'll be using more of the oral pain medication. Some of the pain medication modalities that we utilize are epidural catheters, which are the ones that go on your back. There's also peripheral nerve catheters. That's medication that's given close to the incision site. There's patient control analgesia, which is the device that you see up on your right. And that's just a pump that you get to press on whenever you have pain. So you basically get to administer your own pain medication. But don't worry, it does lock out, so you will not overdose. And then, of course, there is oral pain medication, which is what you'll be getting discharged with. So unfortunately, some of the issues that we get to deal with are nausea and constipation after surgery. So the nurse will be giving you medications if you do require some antiemetics as well. After surgery, you will come out giving hydration through your vein, and ultimately we want to make sure that you're able to tolerate clears and then eventually transition over to orals. It is important to eat sufficiently so you get enough energy to heal better and then move around and work with physical therapy, okay? So make sure you stay hydrated, drink sufficient amounts of water. So in terms of mobility, we want to make sure that we get you up and moving as soon as possible. We want to make sure that your muscles are strengthened and that you move as much as possible. We want to make sure that when you do get up, you get up safely. So the physical and occupational therapist will be teaching you how to do that appropriately. And we want to make sure that when you get up, you do call us. Press that button. I don't want you to get up on your own because we are giving you narcotics and other medications that might make you a little droopy. So it's important that you call us before getting up. Some of the things that you will see if you'll be going up on the tour would be the overhead frames and trapezes. There's front wheel walkers in every room. There's a bedside commode and plenty of assistance from staff. So after surgery, some of you guys might have a little bit of swelling and redness that might be normal. You just had surgery. But to reduce some of that swelling, we encourage you to change positions every hour. You should be sitting less than 1 hour at a time. And we do encourage you to eat your meals up on the chair if possible. That's just to help you take those deep breaths that you need to, okay? If you do notice a swelling at that surgical site, make sure you elevate that leg if possible, just to reduce some of that swelling. You should continue doing this for 6 to 8 weeks after surgery. All right, so another thing that we focus on is preventing clots, blood clots, or deep vein thrombosis, the fancy name for it. Some of the things that we utilize are the sleeves that you see up on your left. Those are called sequential compression devices. The purpose of this is to help you improve your circulation and prevents blood pooling, preventing blood clots. So ultimately, if you do get a clot that can travel up to your lungs, your heart, or your brain, it can lead to strokes and pulmonary embolism. So we really try to avoid all that. So we do give you those sleeves to use, and what they do is they help massage your calves. We also give you subcutaneous medications or anticoagulant medications like Lovenox, Arixtra, and heparin. And there's also oral medications like Coumadin, Xarelto, and aspirin. And you'll be doing plenty of ankle pumps, and the physical therapist will be teaching you how to do all that. So after surgery, especially if they utilize general anesthesia, your lung muscles relax, so you might not be taking those deep breaths that you need to take. So we want to encourage you to cough and take deep breaths as much as possible. So a way to do this is by utilizing this gadget right there. It's called an incentive spirometer. The purpose of it is to help you expand your lungs and to help get oxygen to your tissues. It prevents complications like pneumonia. And you will be using this 10 times every hour while you're awake. The nurse will be teaching you how to use that. So we want to prevent infection. That's a big one here. We want to make sure that if you do have drains, if you come out of surgery, sometimes you'll come out with these drains, the ones that you see up on the top. These are placed to reduce swelling around the incision site, and they're typically removed based on the amount of output. It also helps heal the incision better. Everyone is going to come out with a urinary catheter. I know no one wants that, but it's very important to want to make sure that you don't have an accident while they're doing surgery. That's going to come out that first day after surgery, and we want to successfully transition you over from the urinal, the bedpan, and onto the bedside commode. So we want to prevent infection. If we prevent infection, we can prevent complications and thus heal better. It also prevents readmissions if we can control those infection rates. So in a way that we implement to prevent infection is implementing a 24-hour post-op IV antibiotic regimen. We encourage you to wash your hands frequently, especially before eating. We'll be giving you sanitizing gels also available. And the surgeons will be doing your dressing changes right before discharge. We want to make sure you're aware of the signs and symptoms of infection like redness, swelling, drainage, and fever. So the big important day is that day of discharge, which is typically post-op day 2 or 3, depending on your progress. So the physicians will be coming in the morning telling you that you're going to be discharged. That does not mean that you're discharged right then and then. You have to wait for an official discharge orders on the system. And then the nurse has to coordinate everything in order to discharge you. But at that point, you can start arranging your transportation. Usually discharge is around 11 a.m. Before discharge, the nurse will be going through important information that pertains to your discharge, such as activities such as showering, driving, no driving while you're taking narcotics, very important. They'll be teaching you about incision site and dressing changes. They'll be discussing follow-up appointments. They'll be talking about when to call your doctor, also home health and physical therapy orders. And then a big one here is, it says we provide prescriptions or discharge medications. So before discharge, the pharmacist will be coming at bedside. They'll be giving you your discharge medications, and they'll be asking in return for a copay. Usually is about $25. So we also encourage you to take pain medications right before discharge, especially if you have a long car ride home. All right. So now you're going to hear a little bit from pharmacy, and afterwards we'll be going through a tour up on the orthopedic floor. Thank you.
Good morning, everyone. My name's Jason. I'm one of the pharmacists here. And I'm going to spend the next probably 5-10 minutes or so just reviewing some of the medications that you'll be receiving here at the hospital and some of the medication related issues surrounding the medications that you'll be getting here. But first, we probably want to start off from the very beginning and make sure you talk to your physicians before coming in for your surgery. We want to give you some helpful hints about what to discuss before surgery. So anytime you come in for any type of procedure, you want to make sure that your most current information is updated in the chart here at UCLA. So one of the things we always ask are usually things like, do you have any allergies and what allergies you have? So we always want to make sure that those allergies are updated. We also will ask for adverse reactions, and also keep in mind that you also want to inform your physicians or your nurses about any adverse reactions to drugs that you've had in the past. So these aren't necessarily what we commonly think of as allergies, but these are reactions that you've had in the past that may have caused you to stop taking a medication. So things that caused you to stop taking a medication could be things anywhere from, it made me way too sleepy or just made me too nauseated. And some of you may have experienced that. A lot of times that's helpful for the physicians to know beforehand, because a lot of the medications that we give you here are pretty standard, but they're also standard medications that a lot of people use out in the community, like your pain medications. And if you've had a bad reaction to that, we really don't want you to start off having another reaction and while you're here in the hospital. So if you've had something that really caused you to really stop taking a medication in the past, let them know, and then they'll put it in the chart and said, oh, Mr. Jones had really severe nausea from this, and then the physicians here will know, oh, we can try an alternate agent while you're here. They'll also want to review your current medications, and that's not only before you come in for surgery, but usually at all points of care. You'll notice that when your nurses come on board for each of their shift, they'll want to know what medications you were taking beforehand. And a lot of times the physicians and the anesthesiologists beforehand, they'll want to know what you've recently been taking. So they'll go over your prescription drug history, so things that you're on for any chronic disease states that you have. Anything that you've taken over the counter, things like Tylenol, any cough medicine, because a lot of those medications also are contained in the medications that we have here, so we don't really want to give you too many doses of the same medications. Vitamins and herbal supplements are also important for the physicians to know. They could screen through that to make sure that there are no drug interactions there. So if you are taking vitamins or herbals, a lot of times you may not need to take it here, but they'll want to know that you've taken it recently so that we can screen for any interactions. And again, you'll be asked this as a common question while you're here, just because a lot of times the nurses want to know that what the physicians have ordered is the correct medication that you're taking at home. Because once you are able to take your oral medications, the physicians will prescribe those for you to be continued while you're here as well. And then your discussion with your physicians or your team beforehand should also discuss what medications, if any, should be stopped before surgery. The most common class of medications that are stopped prior to surgery are blood thinners. So obviously we don't want to have any blood thinners in your system to cause any complications during surgery. But depending on the blood thinner that you're on for any type of arrhythmia or previous clot that you've had, may need to be stopped anywhere from 2 days beforehand to up to a week beforehand. So you may want to discuss that with your physician, let them know what exact medications you are taking, and they will instruct you as to how long in advance to stop those medications, or if there's any alternative that you need to be taken while you're preparing for surgery. And then the use of personal medications is not allowed. So the pharmacy here will provide you all the medications that you'll receive during your inpatient stay. If there is a medication that you need or that you know that was hard to obtain, special medication, make sure you tell your physician. They can contact the pharmacy and we can work on trying to get that medication for you or work on a plan to make sure you don't go without that medication. Now, during and after surgery, you'll be given antibiotics. Like the previous presenter had said, that antibiotics are usually given for 24 hours around your surgery, and this is really to prevent any type of infections that you may have, or prevent any types of infections that could occur. So what people may not realize is that there are naturally residing bacteria that just reside out in the environment, so we want to make sure that bacteria during your surgery doesn't cause you any infections while you're here. So there are preventative antibiotics that we normally give. The most common is Ancef, and the second most common is vancomycin. So Ancef is the cousin of a penicillin. So if you have had penicillin allergies in the past, make sure your physicians know. They'll probably prescribe you that vancomycin instead. And again, it's really limited to one dose or just 24 hours worth of antibiotic while you're here at the hospital. Pain control. Now, pain control, for obvious reasons, for any type of surgery is going to be the most common medication that you'll receive here. We want to make sure that we are treating your pain effectively and making sure that you are comfortable. So we do have various drugs that we use to prevent and treat pain. The most common of those drugs are going to be from the opiate type of class that we have here. So you may or may not be familiar with them, but the most common ones we use here at the hospital are hydromorphone, and the other name for that is Dilaudid, and morphine. Those are common medications that we give IV here. So usually right after surgery, you'll be given pain medications through the IV route. And once you're able to take oral medications, we can start giving you oral opiates, oral opiate, and analgesic combos like you see listed up there. The hydrocodone and acetaminophen combo, which commonly go by Norco or Vicodin, or oxycodone and acetaminophen, which is Percocet. Again, these are from the opiate type of class, and if you've ever taken these before, we've always said that, that these drugs could make you sleepy. So depending on what dose of drugs that you have, we want to make sure that, like we said before, that you're not always getting out of bed, you always have assistance. We want to make sure that you're not too sedated while you're taking some of these pain medications, and your nurse will assess you for those as well. And along with those side effects and that come with these drugs are things like itchiness, nausea, constipation, and we'll talk about a little bit of how we treat those side effects while you're here. The NSAIDs, or the non-steroidals, like ibuprofen or naproxen, are usually reserved for milder type of pain, and usually we give those a few days after your surgery, if any. Again, the opiates are the most commonly used medications that we provide here to patients. You'll get your pain meds, like I said, through the IV or oral route. The other thing that we can give you is the patient-controlled analgesia part, which, if you remember seeing in the previous slides, it's a device where we hook up some IV pain medications. You'll have kind of a clicker that your nurse will give to you, and anytime you have pain, you can press the button, and small doses of those of the medication will be delivered to you. And like we said, there is going to be a lockout interval to make sure that you're not getting too much of those too much of the pain medications, but it is quite effective in controlling your pain because you yourself will be able to deliver those medications to yourself at the time that you are in pain, and not have to have the nurse come in and give you the pain medications and wait for them to get the medications from the medication room. So that is the added benefit of that. Patches are sometimes used to be applied to the skin, but patches really are reserved for patients who we know already have a stable pain regimen, and we know that they're going to be controlled on that, because the thing with patches is that we need to know how much pain medication you're on, because it does deliver kind of a constant rate of medication to you. Now we'll talk about the medications to treat or prevent any of the side effects. So like I said, the pain medications can cause some side effects. Sometimes the anesthesia itself can cause some side effects. So the most common side effects that our surgical patients have in the hospital are listed up there. So nausea and vomiting. We can give medications like Zofran or Reglan. Those are kind of our common antiemetics or anti-nausea medications. Constipation can be a common side effect of the pain medication. So while you're here in the hospital, we'll give you regular doses of Colace and Miralax. Those are kind of like your stool softeners to help keep you regular. And if you are having problems where you are feeling constipated, we do have things like Dulcolax and Fleet's enemas that we can give you. Insomnia can be a side effect of any type of hospitalization or any time that you're just not in your bed because of it's not your routine. So we do have some sleep aids here. Ambien and Restoril are our common sleep aids, and acid reflux and indigestion can be a side effect of hospitalization and any time that you're not on your normal diet. So Pepcid and Protonix are things that medications that we have here that we can give you. Maalox if you have indigestion as well. After surgery, your nurses and your physicians will tell you that one of the side effects that we want to prevent is the formation of blood clots from forming. So if you remember in the previous slides, there are mechanical devices that help prevent those blood clots, but we can also give you medications that will help prevent those. So the most common ones are Lovenox, heparin, or Rixtra, and these are given as shots underneath the skin. And for oral medications, we can give you Coumadin. The other name for that is warfarin. Or what's commonly used now is Xarelto, and that's not listed up there. But again, that's an oral anticoagulant. So the thing about these to know is they are blood thinners. We tell you to stop them before surgery, but for certain patients, we'll ask patients to continue on these for a short period of time after surgery, and sometimes it's limited to your hospitalization, and sometimes it could be for a couple weeks afterwards. It depends on the surgery and your risk for forming these clots as well. But the thing to know here is that if you've ever had problems with bleeding before, where you're kind of like an easy bleeding, or you've had a history of GI bleeding or blood in the urine, or you're one of those people that has easy bruising, just make sure you tell your physician so that they can dose adjust these medications for you. There's always room to adjust these medications so that they're safe to be given while you're here in the hospital. Okay, and that's it for me.
We're going to skip ahead to the case management portion since our case manager is here. Ooh. Just kidding.
Hello, good morning. My name is Susan. I'm one of the case managers, and I will just be discussing this portion of your stay for your scheduled surgery. Okay, so there's 3 different options of discharge when it comes to after you have your procedure completed. One could be you could go home and you would have outpatient physical therapy if your physician has approved that. This would require you going out 3 times a week to have your therapy done. The second most common is your home with home health. Okay, that would bring an RN would come in and make sure that your wound is healing and your medications you're taking are appropriate, and see what other kind of questions you might have. But most importantly, the PT and OT would be coming to your home. All right, and then after that, you would graduate into outpatient PT. All right. The third option would be a skilled facility. It'd be therapy in a rehab facility. Those are for when if you just need intense therapy and you don't have help at home, or you may need you may have a lot of stairs and that might be difficult for you. Okay, so we would help arrange going to a facility. So let me talk about durable medical equipment here real quick. Depending on your insurance, like Medicare covers 1 item every 5 years, and that's 1 walking item. So anything that assists you with movement, like a walker, a cane, or a wheelchair, any kind of ambulation. Okay, so if you've received a walker in the last 5 years, Medicare will not cover a second walker until after that. Right. For those of you without any kind of DME insurance coverage, you can pick up this equipment at any DME, any kind of medical equipment store. Walgreens, CVS, Rite Aid, those also have it. Okay. We will order your walker if you need one. If you have one at home, I encourage you to bring it so that PT can look at it and make sure it is in appropriate shape for you to use and safe. Other items that may not be covered by insurance would be like a bedside commode or a toilet riser, shower bench. If you're having a hip, you might need the grabbers, and they'll talk about those later in your presentation. But those are not covered by insurance, okay? So I want to make sure that when you come in, if it's something that you will need, it will be an out-of-pocket expense. So if you have friends or family that you could borrow those items, or you could go to a Goodwill or a Habitat for Humanity, you can get that stuff at very reasonable prices that you can use. Okay. And if you need a walker ordered to your room or any of these other items, we can do that. The case manager will do that when you are in your hospital room. Okay. Very good idea if you don't have Medicare to check with your insurance provider on what will and will not be covered. Okay. So if you go home with home health, we'll set that up for you here. The case manager will do that. The agency will call you to make the visitation appointments. You are in control when it comes to your home health. So when they call you, you let them know what's a good time for you, for them to come, okay? They usually they call within 24 hours and visit within 48 hours, right? So then your physical therapy and your occupational therapy, it would be a separate person that would come 1 to 3 times a week. They'll give you an evaluation, and then they'll set up the times with you on when to come to do the exercises, all right? And then, again, you might want to, if you don't have Medicare, you might want to check with your insurance to see what home health coverages there are. So back to the skilled nursing facilities, the rehab, it's short-term rehab, which means you'll get therapy 1 to 3 times a day at the facility. You would actually get a room and look like your hospital room here. And then if you have Medicare, it covers days 1 through 20. There's no charge. After day 20 to day 100, there's a varied level of percentages that you would be paying to the facility. Most of the times with a hip or a knee, usually knees can go home, but if a hip usually would stay about maybe 2 weeks at the most. So you wouldn't hit your 20 days most of the time, okay? Transportation may not be covered as well under your insurance. Most Medicare does not cover that unless it's an emergency. So we will help you with arranging transportation. If it's something that you can get in and out of your car with the help of us, that is more cost effective for you. Other words, if it's safe and we can justify why you need the ride in an ambulance, we can do that. Okay. And we'll arrange all that for you. What happens is you'll have a case manager come in your room at the day after your surgery and just talk to you, verify your address, verify what kinds of DME equipment you have at home, what you need at home, what kind of support you have at home, what is best for you based on what PT is recommending, whether you go home with home health or outpatient therapy, or if you go to a skilled facility. Okay. Again, if it's non-Medicare that you have, please check with your provider to find out what coverage you have for skilled. Some of the private insurances do not cover skilled.
Good morning, everyone. My name is Gladys. I'm one of the physical therapists here on staff. And we will be going over what the role of physical therapy is during your hospitalization here. So physical therapy will typically start on the day of surgery. So if you have an earlier surgery time and you're out of surgery and out to the floor, let's say by like 2 or 3 o'clock in the afternoon, we would do our best to try to see you the same day as surgery. If you are one of the later surgeries, then we will see you the following morning at the latest. Some of the things that we will be working on while you are here are regaining movement, regaining strength, walking, and being able to negotiate stairs if you need to do so to go home. If you're having hip and knee surgery, we will be seeing you twice a day, except if you're seen for your evaluation on the day of surgery, you'll only be seen once because it will likely be between 3 and 7 p.m. If you're having spine surgery, you will be seen once a day for the duration of your stay. Occupational therapy will be coming by on postoperative day 2 to do their assessment. So depending on your surgery and your surgeon, you may have some activity restrictions. So there are certain positions that will cause excess stress on your new joint and potentially increase the risk of dislocation. So there are a couple things that you might need to keep in mind depending on which surgery you're having. So, for instance, if you're having a total hip arthroplasty and it's being done via the posterior approach, we request that you do not cross your legs, do not bend past 90 degrees at the hips, and do not turn your legs inward, so no internal rotation. And typically you will be weight bearing as tolerated, which means that you could put all of your weight through your leg. If you're having your hip done via the anterior approach, really the one thing we don't want you to do is the no figure 4 position, which we can demonstrate later. And you will also be weight bearing as tolerated. For our total knee replacements, really we just want you to avoid twisting the knee. Typically also weight bearing as tolerated, as much weight as you can tolerate through your leg. And we want you to avoid having pillows, towel rolls, anything under your knee postoperatively. For spine surgeries, we're going to make sure that you're able to log roll to get in and out of bed. We don't want you to really be bending at the waist, twisting at the waist, and you will have a weight restriction of 5 pounds. So no lifting, pushing, or pulling anything over 5 pounds. If you're having neck surgery, cervical surgery, we don't want you to raise your arms above the level of your shoulder in addition to the rest of these. So typically what we do is we will notify the nurse that we are assigned to you for the day, and we do our best to work with them to try to coordinate what is the best time to see you for your therapy. Some of the things that you could also do, though, to make the best out of your therapy sessions is to perform your basic hygiene ahead of time. For instance, if you know therapy is going to be by in half an hour, it might be better use of our time together if you called the nurse for help to get up to the bathroom. And that way, when therapy shows up, we could focus more on the therapy things. If it turns out that we are working together and you do have the need to use the bathroom, we are more than happy to help you, though. Working your meals around therapy would be good, too. Here we have more of like a hotel concierge type of service where you go ahead and order your meals at your own leisure. So we don't necessarily know when you're having your meals, but you might know when we're coming. So then you could work your meals around that. Addressing toileting needs as mentioned. And also if you know that we're going to be coming between 10 and 11, say, and you have visitors coming that you may or may not want to be present, working that around as well as phone calls, any important phone calls that you might need to make. And we, as I mentioned, will do our best to coordinate your treatment sessions with the nurses, but it's also your responsibility to make sure that you have good communication with the nurses as far as your pain control and pain management. So what happens on the day of evaluation? So we will come in, we will likely ask you a couple questions about your home setup and what you were able to do up until that point, just so that we know what we need to work towards. We will go ahead and assess your mobility, and see what you're capable of doing on that day. Our goal is to have you stand up and walk on the first day if everything looks good. So as long as your strength and your sensation in your lower extremities looks good, we will definitely try to stand and potentially walk. And then we will discuss discharge. So after we've completed our assessment, we'll discuss with you based on, how much assistance you have at home, the resources that you have available, that kind of thing, to formulate a plan as far as to whether you would be going home from the hospital or to a rehab facility. And then at the end of the session, we'll go ahead and let the nurse know how you did so that they could continue to help you mobilize. So we'll let them know how much assistance you needed to get up, that kind of thing, whether you used a walker, crutches, we'll update them. And then the subsequent daily treatments will kind of just focus on what it is exactly that you need. For instance, if you're moving really well, but you had your knee done and your range of motion's not coming along so great, then that would be probably what we would focus on. But the overall picture will be just making sure that you're mobilizing safely and that your strength is improving as well. So most of our hip and knee surgery patients will be seen up until the day of discharge, and our spine patients can be discharged at any time as soon as they've met their goals. So our goal is to prepare you for a safe discharge to home by the second day after surgery. And some of the things that you should be able to do with little to no assistance to go home are get in and out of bed, walk household distances with a walker, use the toilet or commode, and complete self-care activities with little to no assistance. So if you meet these goals, then typically we would recommend that you go home from here. Any questions? So here's Amy from Occupational Therapy.
Hello again. So as Gladys mentioned, physical therapy starts in with you on the day of or the day after surgery. Occupational therapy may begin the day after surgery, but more likely the second day after surgery. By that point, you've mobilized with physical therapy and your nursing team. You've also been disconnected from a number of lines and drains and things that might kind of be in the way and preclude us from doing some of the functional activities that we will do with you. So occupational therapy focuses on things like getting dressed, getting in and out of the bathroom, making sure you're able to use the toilet, also getting in and out of the car, any home management skills that you might need. We might review, not a lot of space in our environment to go to really delve into home skills, but we'll talk about those. We'll talk about your shower at home, what you're going to need to do to get in and out of the shower, what kind of equipment might be useful for you, things like that for home. So preparation is key. As I think you've heard a number of times already today, making sure you have the support system in place beforehand to help with preparing meals, potentially with bathing and for moving around the home. Transport of items can be difficult when you're using a walker, you know, so things like that, maybe help with your ice machine, things like that. If your family has limited time off of work, we recommend that they take their time off starting your post-operative day 2. So that would be, if you've had surgery on a Tuesday, that would be Thursday that they start taking time off of work if their time off is limited. Because up until that point, we'll certainly be here taking full care of you. So at that point, we can work with them and train them to help you and help with whatever needs you may have at home. If you know you're going to need to have a caregiver, you will want to hire that person ahead of time, as when you're in the hospital, it's not going to be the time to be setting that up. However, if that's not something that you can do on your own or that you have access to, the case managers here and social workers here can give you a list of agencies, for instance, for caregivers to be hired temporarily, that kind of thing. So we can also work with you on that. Arranging for any home needs like housekeeping, gardening, etc., in advance so that you'll know that all of those things will be taken care of appropriately. Is your home set up? So you should have or be able to get any of the durable medical equipment that might be necessary. You've heard it already today, but if you do need a walker and you don't already have one, we here at the hospital will help you obtain that. Other equipment like a bath chair or a commode or things like that, those will be something that we could potentially help you get, but you will need to pay for. So if you want to get them ahead of time, you'll find that you'll pay a lot less, and you might just have it set up for you before you get home, just to kind of feel secure about that. It's important to set your home up to accommodate a walker. So if that's not something you've had before, walk around your home as though you're walking with a frame, and just make sure that your hallways are adequate size to accommodate a walker, that you're not going to have throw rugs on the floor that might trip up a walker, no clutter on the floor or piles of things that might be in the way. We also would suggest that any small pets that might be in the way, maybe you have set up a plan for, because if they do get in the way of a walker, it could be potentially a risk for a fall. So here are some of the items that we will discuss with you. We don't recommend that you go out and buy all of these things by any means, but these are just things that are options and available. If you are having a hip surgery, especially from a posterior approach surgery, which is really, I think at this point, still the most common hip approach, we will talk to you about not bending at the hips more than 90 degrees, which basically means that you're not able to sit in low surfaces and you're not able to bring your legs up to you. So as far as low surfaces are concerned, oftentimes your toilet at home will be low. So we would recommend that you have something to raise up the height of the toilet. In this example here, there's a commode over the toilet. So that's kind of a temporary fix that will raise the height of your toilet, and then when you don't have those precautions anymore, you can just remove it. There's also on the very bottom, second to the left there, is something called a raised height toilet seat with arms. That's something that can sit in the toilet to raise up the height of it, and has a little lock on it to lock in place. They have raised height toilet seats of all different sizes. So if you think you just need a couple inches, that would be something you could buy in a pharmacy. Your local Rite Aid and CVS have those items, as well as medical supply stores, and certainly on Amazon you can get anything you want. We often will recommend grab bars. That's something for bathing, whereas we're not always recommending a chair in the shower anymore at this point, because most of the surgeons want you to wait at least 5 to 7 days before you're getting in the shower anyway. By that point, usually you're okay to stand up unless you know that you have a mobility issue that would preclude you from standing, or that you feel unsafe with your non-operative leg being the secure standing point. So we will, though, talk to you about getting grab bars if you don't already have them. And the one picture on the bottom left is something called a suction grab bar. So if installing grab bars isn't something that you think you can do in your shower, a suction grab bar can sometimes be another option, a secondary choice for something kind of temporary, or at least if the surface of your shower does not accommodate a grab bar, or you don't have studs that you can easily get to, then this might be an option for you. Having a non-slip bath mat is a good idea. We just want to set up your bathroom to basically prevent falls, minimize your risk of any falls. So those are things to be thinking about. Maybe non-skid stickers inside the tub if you know that your tub is particularly slippery. These items are the items that come in something called a hip kit. So if you are someone having a hip surgery and you know that you're going to need to be fully independent with dressing yourself, we will probably take you through how to use these different items. In our rehab demonstration in a little bit, I'm going to show you a few of them, so we'll go over that then. But basically, you need to extend the length of your arm if you're going to reach to your feet, since you're not bringing your feet up to you. So that's kind of what these things will help you do. Here are some ideas of setting up your home to be modified for your needs. So as I was talking about low surfaces and not being able to get down to low surfaces as easily, if you put a firm pillow on a low chair, that will increase the height of it. Again, making sure that you have adequate space to wheel your walker around, that you keep items that you use often within easy reach so that you won't have to get up as often. Wearing firm shoes and shoes with a backing are the best type of shoes to wear for safety when you're getting around your home. Moving any electrical cords out of the way, removing throw rugs, and as I mentioned, small pets can sometimes be an issue if they're going to be right in your pathways. So something to consider if you have a way to manage that in a different room or something. If by the time you're leaving the hospital, you are still requiring maximal help or 2 people to help you with mobility, if you're not able to walk or take steps, if you don't have support system, or maybe you can walk but have a lot of stairs that are unavoidable to get into your home, or frequently losing your balance, these would be things that we would consider make a recommendation for going to a skilled nursing rehab facility to help you get stronger and more balanced before you go home. So as you heard from case management, they would help you handle that and arrange for that discharge. So we heard from case management already, and that concludes the speaking part of our program.